Congratulations, you made it all the way to world number 9. I know that you really took a lot from that upper molar with the MB2 live case demonstration, and in this final world of the main course, I wanted to discuss with you when I think you should consider referring your endodontic cases out. Remember, I think you can handle most routine endodontic cases with the training that I've provided for you and with a little bit of practice. But there are situations when you may want to consider referring out for your own good. One of the main reasons why you may want to consider referring out some of the cases that I'm going to describe to you is to stay out of rooms that look like this. And you know what I mean by that. So let's get into it. You have some patients that have severe medical complications and have severe medical considerations that need to be taken into account before endodontic treatment is performed. Remember, endodontics is an unbelievably safe and predictable medical procedure with minimal to no absolute contraindications, but still there are outside factors that you may want to consider. Also, endodontics is a relatively lengthy procedure, and so some patients can't tolerate a long medical procedure, at least not while they're awake. And so you have to take that into consideration for some patients. Also, some patients are wheelchair bound, making endodontic treatment very challenging. And some patients also cannot fully recline, which also makes endo treatment very challenging. So you need to make the decision whether you want to treat these patients or you want to send these patients out. Some patients cannot open very wide. They have some natural trismus that's occurring and they have a limited mouth opening. This may be for medical or non-medical reasons, but this is going to significantly increase the case complexity and may not be something that you want to treat in your general practice. Also, some patients have hyperkinetic movement disorders, such as Parkinson's disease, making the patient's ability to sit still very challenging, if not impossible. Again, maybe not something that you want to see in your practice. And also, some patients just have a very complex medical history with tons of problems, and thus it's going to increase the chance that some sort of medical emergency might actually occur. So you may not want to have that happen in your general practice. You may not feel comfortable with something like that occurring. So these are some of the basic things that you want to consider. Also, some patients are just PITAs, which we all know what that means, the pain in the you-know-what. And you may not want to perform a lengthy medical procedure on them that might involve some post-operative pain and swelling, and you don't even want to deal with that kind of a procedure on those patients. So by all means, send those patients out too. A lot of patients also have a severe gag reflex, and this might lead to an increased number of visits because a lengthy appointment is going to set off that gag reflex. And these patients oftentimes have some history of a traumatic dental experience and thus have a psychological issue with dental treatment and being in a dental office. Also, radiography is very challenging on these patients, and we have ways to modify it by, one trick is to have them raise one leg as you're trying to take your working radiographs to modulate and modify and hopefully curve their gag reflex. Sometimes placing some salt on their tongue helps as well to lower their gag reflex. Also, suggestive language can be helpful in these patients because oftentimes when their anxiety ramps up, their gag reflex gets worse. And in the relatively extreme scenario, which I've done from time to time, these patients with gag reflexes, the gag reflex can be curbed using oral sedation, some form of an anxiolytic medication. But you may not feel comfortable doing that. So these are things that you want to consider before committing to endodontic treatment on these patients in your general practice. Also, some patients that have a severe infection, you may not want to manage that. When you're dealing with a severe infection, it's a different animal than when you're dealing with, let's say, a vital case. Okay, so the patient is very swollen. That might not be something that you want to get involved with. Also, some patients have periapical lesions that are huge, that span 4, 5, 6, 7 teeth. Obviously, those are severe cases, but you might be concerned that you might be dealing with some sort of a oral surgery level lesion, such as ameloblastomas or some other issue, and you may not want to be making the decision as to what it is on the differential diagnosis if it's something that's large like that. So you may want to send those patients out as well. And sometimes the diagnosis is tricky. So I touched on this earlier, but if a patient has very vague symptoms, remember, you want to reappoint or refer that patient. You don't want to make any assumptions as to what the diagnosis is. So if you determine that the patient has vague symptoms and you, let's say, reappoint this patient and you're still not able to come up with a strong diagnosis, you may want to consider sending that patient out so that you don't inadvertently perform endodontic treatment on the wrong tooth or when it's not indicated. And then tooth position can sometimes be an issue when you go ahead and isolate the tooth with your rubber dam. Oftentimes, upper second molars can be challenging if there's a strong buccal inclination of the crown, and that can make your root canal treatment very, very challenging. However, in my opinion, for me personally, if you can restore a tooth, you can isolate a tooth, but that might not be the case for everyone. I've been doing this for a while, and this is all I do. So if you don't feel comfortable isolating your tooth with a rubber dam, and you're even considering performing your endodontic treatment without a rubber dam, do not think about it. Send that patient out. Do not attempt root canal treatment without a rubber dam. Also, if there's limited mouth opening, you technically can perform some pretty aggressive occlusal reduction in order to have the appropriate clearance to fit instruments into the patient's mouth. Don't be shy if you find that you have to do that in order to successfully perform root canal treatment, because the alternative is dental extraction. Also, this is a case that I've treated. Sometimes the prosthetic stakes are so high that you may not want to risk having a perforation occur or something like that. So these long span bridges, if something goes wrong with your endodontic treatment, the patient might end up losing a significant portion, if not the entire bridge. And you may not want to take on those high stakes. So if you feel that the stakes are just too high, send that patient out. Don't aggravate yourself. And then finally, if you find that the tooth is very, very calcified and you think that there's a high chance that a perforation will occur and you don't want to take on that risk, by all means, send this patient out. Not every patient needs to be treated on the spot, and don't aggravate yourself. You have the opportunity to hand select your cases. And just like the Grail Knight said in Indiana Jones, The Last Crusade, when selecting your cases, you must choose wisely. All right? So there you have it. Those are the situations where I think you should consider referring your patients out to an endodontist or elsewhere, as opposed to driving yourself crazy, pulling your hair out, and stressing out your staff, your patient, and yourself in doing everything under the sun, because you don't need to do that. I need to do that as a referral-based practitioner, but you don't have to do that. So hand select your cases wisely so that you can fully enjoy endodontic treatment in your general practice. Thanks.